definitely realizing that birth is physiologic. However, I feel people kind of associate midwifery since the beginning of time with out of hospital births. So it's minimal interventions and everything like that. But with OBs, I see people kind of associate them a lot with cesarean sections and things like that. But I feel like we all have the same goal, just maternal safety, making sure everybody's getting the best care that they can possibly get.
So I think the main difference, I think for the midwifery model from like regular, like the OBGYN doctors, is really the holistic delivery of service that they provide. And I think, one thing to recognize at Brooklyn and I think what makes us so unique here at NYU Langone is because we're able to really provide the entire spectrum of care for the patients.
Staten Islander News is here this morning with Dr. Meleen Chuang and Shawna Paul. Dr. Meleen Chuang is an obstetrician gynecologist at NYU Langone, where she provides compassionate and comprehensive care to women of all ages. She began her medical journey with the Sophie Davis Biomedical Education Program at the CUNY School of Medicine straight from high school, driven by a desire to make a difference in women's health. Her early and unwavering passion for this field has guided her throughout her career. She has a particular interest in managing conditions such as polycystic ovary syndrome, also known as PCOS, and abnormal cervical dysplasia, for which she performs loop electrical excision procedures in the office. Her commitment to proactive healthcare engagement ensures that her patients are well informed and actively involved in their care decisions. She finds immense fulfillment in serving the underserved populations at NYU Langone, Brooklyn, ensuring they receive the high-quality care they deserve. Her philosophy of care is rooted in treating her patients with the same kindness, care, and respect that she would want for her own family. So Shawna Paul is a certified nurse midwife. As an experienced midwife at Sunset Park Family Health Center at NYU Langone, Shawna Paul brings almost 10 years of specialized expertise in labor and delivery, patient education, and postpartum care to her patients. With a special focus on maternal health, she strives for health equity and decreasing maternal morbidity and mortality among all women. Driven by her passion for women's health, she balances her roles as a mother to two wonderful children, one whom she had at only 19 years old, and a healthcare provider, ensuring that women receive the support and care they deserve before, during, and after their reproductive journey. Beyond her clinical practice, Shawna is a tireless advocate for improving health outcomes among minority women and reproductive justice for all women. With her unwavering dedication and willingness to learn, Shawna is making a profound impact on the lives of women and families in her community, ensuring that every woman receives the care and support she deserves. So good morning. It's good to have you both with us.
Good morning.
So I'm just going to ask the questions, and whichever of you would be most appropriate to answer, you can go ahead and just answer them. So the first question I had is, how would you describe the midwifery model of care?
I feel the midwifery model of care is just basically treating birth and pregnancy as something that's physiologic, something that's natural, and trying to minimize interventions as much as possible, but also realizing, safety is number one.
Okay. And how does it differ from the conventional medical approach normally taken by OBGYNs?
I don't think it's much of a difference because I think we all kind of practice the same, just maintaining the safety and definitely realizing that birth is physiologic. However, I feel people kind of associate midwifery since the beginning of time with out of hospital births. So it's minimal interventions and everything like that. But with OBs, I see people kind of associate them a lot with cesarean sections and things like that. But I feel like we all have the same goal, just maternal safety, making sure everybody's getting the best care that they can possibly get.
Oh, absolutely. And Dr. Chung, did you have anything to add to that?
Sure. So I think the main difference, I think for the midwifery model from like regular, like the OBGYN doctors, is really the holistic delivery of service that they provide. And I think, one thing to recognize at Brooklyn and And I think what makes this so unique here at NYU Langone is because we're able to really provide the entire spectrum of care for the patients. When they first start at their initial prenatal visit, Shawna is there, and all of the other midwifery team members as well. So everyone is ambulatory. The midwives are at the deliveries for the patients as a group practice. They see the patients postpartum, and when the patient is completely stable and safe and just doing wonderfully with her baby, like we set them up with birth control counseling, set them up with their next pap smear, and then we just do the cycle over and over again. But I think it's really because it's integration of services from the ambulatory side that provides the risk identification, right? If they're high risk or low risk, engaging the doctors, when that time comes and say, hey, Dr. Chung, this patient's a diabetic now, her abnormal testing is here, can I still see her, for her prenatal care? And then you just kind of like chime in and do a couple of visits for the counseling. Same with the vaginal after cesarean section. That's something that I know in general, a lot of doctors or healthcare systems prefer not to do, and they would cancel the patient for a scheduled repeat C-section at 39 weeks. But again, because we really want to help engage the patients and really allow the patients to provide an opportunity, for their care plan, right? Having the midwife involved at the very beginning is really critical. So even for our patients with 1 previous C-sections, these patients do see the midwives for the entire pregnancy. And then, at the 28 to 32 week, when we get a sense that the patient wants to do a vaginal birth after a C-section, Shawna would do the counseling, and then she would say, but touch base with the doctors. We have one of the other doctors, set up a visit with them. They can really go through with you the risks and benefits of the VBAC. Talk about what happens, in case that doesn't go as planned, and what that C-section would look like, and really allow the patient to make a very informed decision about her choices, from the holistic aspects of what Shawna and the midwives do, and also from the technical aspects and the clinical aspects of what the procedure actually entails, because we are the OBGYNs are usually performing the C-section. One thing that makes Shawna very unique as a midwife is she loves to first assist in C-sections as well. Her goal is not to do C-sections. She wants vaginal birth, so we try really hard to make that happen for all of our patients. But she's also, a lot of the midwives here at NYU Langone, also provides the service of being the first assistant. So that's something that we offer here at NYU Langone. We do have, residents and PAs and other attendings here. It's a very, very, very safe and well-supported institution here at NYU Brooklyn. But we kind of, want midwives that can do it, and they do. So it's really great for the patients.
Okay, awesome. And are there specific births and health conditions or pregnancies rather where a midwife would not be really able to participate, or can any patient have a midwife as an assistant regardless of their
about NYU Brooklyn is that we work so closely, and so our collaborative practice is so amazing that we are able to still see the patients, but we are literally right next door to a doctor that we can consult if necessary. The appointments with the doctor if they need to, or maternal fetal medicine is so seamlessly done that we all kind of pitch into their care at the same time.
Oh, cool.
Yeah.
So what do you find are the benefits of adding a midwife to a pregnant or laboring woman's healthcare team?
I think it's more so the support. And like I said previously, treating pregnancy that it's normal, especially with the day and age that we're in right now, with everything going on, people are looking for something where, a provider where they can, kind of facilitate that. Okay, this is something that normally happens, so let's try our best to let it do what it needs to do, and minimize the interventions and things like that. So that kind of gives people the peace of mind, I feel. And not only the peace of mind, but also getting somebody who does have the expertise and the clinical training to take care of them.
And I think for the midwives, I'm just going to add as well, there are a lot of little secrets that midwives have. When I went to med school at Stony Brook, One of the reasons why I have like this really, strong passion for hiring midwives and integrating them into the labor and delivery unit here at NYU Brooklyn, and also at, the Family Health Center where we're both working at, is really because, I, as a medical student, did all of my deliveries with midwives. And, and doing those deliveries, and then, for the first time and kind of getting used to their process. And then seeing when I was a resident, as an OBGYN resident in Montefiore, where midwifery was not as commonplace, we had more PAs and doctors working. You can see like a night and day difference with just the way that the patients perceive their labor process, so that mindset of like, okay, this is something that I can do. This is normal. Like everyone does it. This is meant to happen vaginally. Let's make that happen. Versus kind of like, the medicalization of like a normal physiological process that happens with, with OBGYNs like we are. This is just the way that we are trained. So finding that right balance between the middle where we have a midwifery model that is very collaborative with the physician, right? And that we kind of like are in tune with each other's sort of like decision making and sort of like processes. We tell the patients the same story, so there's no sort of like differences in opinions about medical indication, about labor progress management. Like we kind of do it together, and I think the collaborative nature of the doctors and the midwives here at Brooklyn is really, really important, because that really allows for the patients to trust us, and that we're like a healthcare team that works really well together to work to achieve like one goal. Safe delivery of mom and baby vaginally. And that's why we have such a low C-section rate here at NYU Langone, Brooklyn. It's about 19%, 20%, at any given time. So we're very proud of that. And I think it's because of the work that we do here with the midwives and with the doctors, and kind of really having that collaborative approach.
Oh, nice. Because I know like I don't think many hospitals use these anymore, but like what you were saying, like the progress management, they used to have like a chart where if you didn't get to the specific points on the chart by a certain time, then it was an emergency. It seems like that's not done as much anymore, where like people are just kind of allowed to labor at least more than they used to be, like rather than like, well, everybody does this, and so everybody has to do it this way.
Exactly. Like the 2-hour mark for active labor, like that, like in my training, that was like, oh, you're on the clock, you gotta go and make progress. But now it's like, look, if the baby looks fine, you have a midwife, like your progress is fine, baby looks fine, you're doing okay. Yes, your labor is a little bit slower, but it's okay. As long as the baby looks okay and you're okay and you want to proceed, let's do it. So it's really patient-centered, and it's really just kind of like driven. Like it's hard to say that, like I may have like a really fast labor process, and I may go from like, 2 centimeters to fully in 4 hours, right? But other patients, depending on the size of the baby, their pelvis, sort of like their desire for pain management or not, and pain tolerance, like it may be slower or faster, and like sort of like there's so many factors that we need to consider. And I think, having the midwives kind of like do their sort of like non-medical approach and say, look, let's just let labor happen before we start rupturing and, making her like, get infected. I think that makes a big difference. And the other sort of like labor support that our midwives do is, the patients do not have to push on their back, right? Like, when I was a resident, you're always pushing on your back and your legs are up in the air and the doctor's between your legs. But I think what makes having a midwife really special is, if the patient doesn't want an epidural, if she wants to push on her side, if she wants, we have like we actually, NYU Langone, Brooklyn, that we actually made a very thoughtful decision to like change our labor beds so that they can actually get into different positions. So even though it can lie flat, it can also like sort of like be like this rotation, and then there's like a bar that patients can also lean against. And a lot of the positioning and repositioning is what helps the baby sort of like make its like labor motion come down and allow the baby to really get down to like a lower station to deliver vaginally. And our midwives are great at doing that. So the coaching, the pushing, the labor support, the different techniques that they do to help, with the baby rotate, like these are like really just midwifery, like magic,
Yes.
Yeah, I know one of the things that a lot of times is overlooked in the OBGYN model is there was this book that I read years ago called Childbirth Without Fear by Grantley Dick Red. It's a very dry, kind of boring book, but the whole purpose of it was to explain, like, for example, when you're afraid of something else, if you're afraid, you tense up.
Yeah.
And you get all tight. And the same thing can happen with the cervix. If you're afraid you're going to have pain, you have pain and you tighten up. So it's kind of like, when he went around the country and interviewed all kinds of people and stuff, and he found people who their labor was easier because they weren't afraid. They were like, oh, I'm not going to have pain. There's not going to be any pain. It's not supposed to be painful. And then it wasn't. So it was kind of like a self-fulfilling thing for some people. Do either of you guys, I mean, whoever wants to share first, do you have any success stories that you can share where the addition of a midwife to the team helped a woman in a difficult labor to have fewer interventions or a non-surgical delivery?
I remember seeing one of our midwives, Kylie, while I was on orientation. There was a patient who was pushing for a very long time. She did have an epidural, so her feeling in her bottom kind of wasn't where it needed to be for her to push effectively. And Kylie was talking about this course that she took called Spinning Babies, where, position changes, like Dr. Chuang said, kind of facilitates the rotation of the baby to help for an easier labor. And they were beginning to talk about whether they would need, operative delivery, like maybe a vacuum or something within the next hour or so. Not at that moment. And Kylie had did one position called the flying cowgirl. And within 15 minutes, she pushed the baby out. 15 minutes. I said, okay, this is amazing. Yeah.
And like for me, when I do more of the deliveries, I don't do as many deliveries now because now I'm the chief of service for NYU Langone Brooklyn and still the medical director for the Family Health Center for Women's Health. I think, whenever we have a patient, especially like their first time pushing, the nulliparous patient, when I come on to start my shift and I see, okay, my person, my Wednesday person was Jenny Zhao, one of my midwives here. And, and a lot of the midwives here at NYU Langone Brooklyn, like Shawna, they were L&D nurses. So they really capture the best of both worlds. They know both the clinical aspect of what labor is actually like as the provider standpoint and counseling patients and delivering them. And she also knows, they all know like what it is to, do the nursing components of like the little care and the little TLC and, all the soft little things that, nurses are wonderful and really good at doing naturally. So I think it's really great. So for me, when I see, patients for the first time, especially if they're like teenagers, like younger, we have a lot of, younger patients here, I think that's like the perfect time to like engage them to, really have like that labor support and that, that early intervention kind of like, look, this is a midwife, the doctors are here, but, they really don't, need to participate. Like, it's Dr. Chung, but Jenny, I'm going to be the one managing you today, and it's just kind of like, and in case if there is any sort of like, emergency, right? Like, postpartum hemorrhage or like any, the shoulder is getting trapped a little bit at the time of delivery, or if the patient needs an operative delivery, like a vacuum assisted delivery, like it's only, in order to get the baby out or because we have to manage this emergency, you're at the hospital for this reason. That's why the doctors jump in, right? Like you want them because that's why you're there, just to make sure that 90% of the time, everything's going to be beautiful and routine and completely fine. But that, 10% when, things get a little bit hairy, you're at the right place, at the right time, with a team of support that the midwife and the patient needs to make sure that things go perfect.
Yeah.
Oh, cool. So what are some ways that an individual can prepare to have the most positive birth experience possible, like before they are, like in the months leading up to the labor and delivery?
It's all you, Shawna.
Yeah, I think honestly, being well-informed and well-educated, my favorite question to ask my patients in their prenatal visits at every single one of them, Do you have any questions or concerns? Because now is the time to ask them to make sure you're fully prepared for what will happen and can happen in labor. I try to do my little education piece at every visit as well. Okay, this is what to expect. And like you said before with the book about the pain, I like to call it a pain with a purpose. So everything you're going to go through is for a purpose, and you can do it. Women have been doing it since the beginning of time, so it's not anything new. But definitely stay well informed, because the worst thing is to have a patient going through labor who does not understand anything. And then things are just being thrown at them, especially in emergency situations. And, you know, like you said, people get scared, they get tensed up, and that can only harm the situation. You understand what I'm saying? So definitely well informed, well educated. Make sure you got a great support team like NYU Brooklyn. Just things like that, just education, and ask questions.
Yeah, and I think it's also a trust issue.
Yeah.
I think, engaging in prenatal care in the first trimester is so important. That's like actually a really big health quality measure, is the initiation of timely, prenatal care in the first trimester. Because, prenatal care, like there's 13 visits. From the time that, she gets pregnant to the time that she has her baby, there's going to be at least 13 visits in the prenatal care time period. And, for us, it's to identify risk. Oh, does she have diabetes or hypertensive or anything that might be, weight gain, excessive weight gain, whatever it is. But I think a really important part of it is also establishing that level of trust. And I think, we work as a team really well. At FHC, there's 5 midwives, and there's like 8 to 9 doctors. They all really work well together. We do let the patients know that, there's always going to be, a doctor at the delivery, of course. But the midwives, if they want it, they got it. And even if they don't want it, they don't think they need it, they still have it, So it's just there for them to provide a layer of support. So I think that makes us really unique. And I think, it's really the collaborative approach. It's not like, there may be some practices or some institutions where we have midwives at the hospital, but they're kind of like assigned to a patient, and there's really no sort of like prior relationship between the patient and the midwife or the doctor. So you have to kind of earn that trust as you're going. And that may not be ideal, because the patient's coming in sort of like in this unfamiliar environment, now with unfamiliar people. The really great thing about, the 2 practices that we have here at NYU Brooklyn is the Family Health Center has the midwives that see patients in prenatal care, and the faculty group practice also has a growing midwifery program as well. So we really try to be very, thoughtful with our approach. And I think earning that trust, from the very beginning is really critical.
Awesome. And do any of your patients, back to what you were saying about being informed, if they want to get reading material, like either books or websites, do you guys have things that you recommend to a lot of your patients?
Absolutely. Not only do they see providers, but in each trimester, they also do a visit with the nurse, where the nurse kind of reiterates a lot of the education. We give out reading materials. We also have community health workers that connect patients with resources outside in case they need anything. We also have a program if they were to be diagnosed with like diabetes. We have a program where we have a community health program that distributes meals, nutritious meals to diabetic patients and their families. So it's like information galore in the office. So it's not anything that they need to know that they aren't able to get before they walk out that office after their visit.
Yeah.
Cool. And what percentage of women could benefit just in general from adding a midwife to their birth team?
I think a good percentage, because a lot of studies show that midwifery births have less interventions than births attended only by OBs. So at this point, I feel like anybody can benefit from having a midwife at the delivery.
Because I know a couple of years back, I forget what the name of it is called. I think it's the National Alliance of Midwives. And they had published their statistics versus OBGYN statistics.
Right.
And one of the things that a lot of doctors found really striking at the time was that a midwife-led birth
Mm-hmm.
can have a 5% C-section rate on average,
Mm-hmm.
which is very low.
Very low.
And some of the doctors were like, how did you get to that level?
Mm-hmm.
And they were just like, because of, like what you were talking about with the midwifery model of care, where it's a physiologic thing and it's holistic, and you just, most of the time, as long as the baby is okay and the baby's heartbeat is okay and all the other indications, you can just wait.
Right.
And so if they just wait, then they don't end up with the interventions. And like you were saying, how that's kind of the goal is to reduce the interventions, because with every intervention, you can get more interventions.
Exactly. Yeah.
Yeah. I think that's the key, and I think we sometimes like we overdo sort of like things, that may not be necessary. And I think one of the things that we, that brings it up is, the C-section, right? Like we give people a lot more time now than before.
Mm-hmm.
So, as long as there's no infection, mom is making progress, baby looks good, we really try to let the patients labor. And I think, the midwives really are like that advocate, being L&D nurses and kind of like seeing that for, many, many years, a lot of the reasons why they become midwives. And I'm speaking, I guess, for you, Shawna, but
Yes.
I think they see a lot of like what's going on, and they feel like they should, that things are done either really well or it could be done better. I feel like they feel, midwife, like nurses, when they're being L&D nurses, feel like inspired to say, like, I want to do something else. Like, I really want to make a difference, and I want to be able to like do something different to really help the patients. And I think that is really the motivating factor for labor delivery nurses to become midwives.
Absolutely.
And in your hospital, what percentage of births approximately are attended by midwives? Is this something for everybody, or do a lot of people make that choice?
Yeah, this is a very more nuanced question. So NYU Langone, Brooklyn, and I have the numbers. Last year we delivered 4,250 babies. So about 30% of our deliveries, about like 12 to 1,300 of our deliveries last year, and every year is from the Family Health Center. So the Family Health Center has 5 full-time midwives. So a lot of the patients that do, and they have a pretty low C-section rate. FHC has a low C-section rate. The NTSV is about 22 to 23%. So and I think that's because we do a lot of midwifery support. So I would say probably, would you say like 30 to 40% of all the FHC patients have midwife involvement, or would you say more?
I would think probably more, because it's maybe just like a Saturday or Sunday that it may not happen. But then we also have the FGP group, who also has midwives also, who attend a lot of the births. So it's a pretty big percentage.
Yeah, so FHC is about 40, maybe 45% of all of the deliveries are attended by midwives. So these are like NSBDs, like the C-sections are usually not attended by midwives. And then for about 20% of the total volume of Brooklyn, so about 20%, so about 900 to like 1,000 deliveries is from the faculty group practice. And that, we're really trying to build a program once we have more ambulatory space, because we want to have the same model, right? We want to have, both ambulatory presence for the midwives as well as L&D presence for those patients to see the familiar face. So right now they only have 2, but we do have plans to grow the program there as well. It's more of a spacing issue. So their attendance is a lot lower, but their volume is also lower too. And then the other like 40% of the deliveries at Brooklyn is from the faculty. It's from voluntary faculty, meaning they're the private attendings that are taking care of patients within the community. We have one large Orthodox Jewish population, the ODA, it's called the ODA group. And, they also have, I want to say they have at least 3 midwives, but their midwifery model is really like when the patient's in labor, the midwives come and they meet them in ambulatory care. So they do 24-hour call coverages for their patients, and they really work to like deliver the patients vaginally. So their delivery rates, of course, is really, they do about 800 deliveries a year, 700 to 800. They have pretty good attendance with midwives, and the lowest C-section rate, it's like at 12% or something ridiculous. Like none of their patients have C-sections because of just the, it's cultural, right? And you have to call a rabbi before you can start oxytocin. You need to call it rabbi if there's any consideration for induction that's medically indicated. So I feel like they also have like that extra layer of safety. So like the rabbi is, I would say the rabbi actually has like knows the indications for inductions and intervention better than some OBGYNs out of residency. Because they've been doing it for like 40 years. Like, what's the indication? What's her AFI? What's the tracing look like? How many, how are her contraction patterns like? We're like answering all these questions before we can get permission to start Pitocin. We're like, wow. So I think it's really great. I hope to grow more of our presence. So, right now it's a little bit, on paper, like when we actually look at the Department of Health looks at numbers and the News and World Report also looks at the percentages of like NTSB being attended by midwives. I think for Brooklyn, it looks artificially low. I think, what was it, like 7 or 8%, but it's really higher because the delivery, the delivering clinician is always the doctor, on file, because there's always a doctor around, and it's like more of a ease of billing. Right. So then the midwives are kind of like so the delivering provider and like the delivering clinician is two different things. And what we send out for reporting is a delivering clinician, which is usually the doctor.
Right.
The delivering provider is a doctor, so that's the one we run, and then delivering clinician is the midwife or the resident. So that usually gets hidden, but it's much higher than what we're reporting. We hope it will only get higher. Like, it would be great to have like more midwives.
And actually, kind of what you were just talking about with the billing and all of that stuff, is midwifery care generally covered by health insurance? And what are the options in cases where it isn't, like specifically with your hospital or in general?
I believe they are normally, especially like in New York State. The good thing about a lot of the midwives in New York State, especially when we have collaborative practices, is that we do cover like a great amount of Medicaid patients as well. I know a lot of our population are Medicaid patients. So when you come to these clinics, I think that's why Dr. Chuang also feels it's very important to get the midwives in the clinics as well, because otherwise than that, they may not have access to midwives. Like if you wanted to do birthing center and things like that, I don't believe midwifery services are covered that way. So it would be of out of pocket expense for them. But when you have the midwives with the collaborative practice inside the hospital, they also get that kind of care, but they're not coming out of pocket thousands of dollars, just to see a midwife.
Yeah, I think that's the secret, that you're sharing. The fact that we're able to integrate the midwife in a way that is covered by insurance, especially like, one thing to know, is just, sort of like health disparity, right? Like the one thing you cannot ignore. And this is why, I'm working at Brooklyn, and this is why Shawna's working at Brooklyn. It's just, Brooklyn is really like the mixing pot of, culture and ethnicity and races. And, at the same time, we really do see all of the health inequities that are present. And, I think that makes it even more important for us to like be very intentional in saying like, look, the Family Health Center is a center where we are providing services, to like the most marginalized patients. They're the most vulnerable. We cannot guarantee, what life will be like once they're done with their pregnancy. There's only so much that anyone can possibly do for patients that are just struggling. FHC has these amazing resources and support services and centers and, financial programs and daycares and adult centers. Like it's really like a collaborative approach with the community of what they offer. But during the pregnancy, at least we can guarantee, a peace of mind, that the patient, during her pregnancy, while she has everything else that she needs to worry about, the pregnancy is the last thing that she has to worry about. But she knows that she's going to be taken care of. She knows that she's safe. She's at a, hospital already getting the services that she wants, which is with a midwife and, with doctors, sort of like there to support, the midwifery team. And, and I think the most important part is that, having the midwives there to provide the care. And in the case of emergencies, I always, hate to bring this stuff up, she's at the right place. And again, you're at the right place at the right time with the people that you need there to take care of you, right? So who are they? You have your midwife there for your support and to deliver you vaginally. You have the obstetrician there to, the primary obstetrician that's, in charge of your care and dictating care, and if need be, intervene for the hemorrhage or for the obstetrical emergency that you may have with an emergency C-section in case that baby's not coming out, to save the baby's life. And we have anesthesia support here 24 hours a day. These anesthesiologists are specially trained obstetrical anesthesiologists. Like, they actually did a special fellowship after their normal residency training of 4 years to do another year or two of like specialized obstetrical fellowship, because they do have like a vested interest in taking care of obstetrical patients and managing, these OB emergencies. And these OB emergencies, when we're talking about, hemorrhage and, the leading, cause of, more maternal morbidity is, hemorrhage and stroke and preeclampsia now. We have our OB anesthesiologists that are, basically critical care, anesthesiologists taking care of patients if that ever needed to happen. And I think the final layer of safety, and this is more in broad spectrum, very particular to NYU Langone, Brooklyn, and the NYU system. So we have Long Island and Manhattan as well. Like, we're like the baby sister of Manhattan, is the obstetrical safety officer program. And this is a program in which it's extremely unique to NYU, in which we have these 5 safety officers. The minimum number of years of experience that they have, in like the youngest one is 15 years out, like 15 years of attending OB/GYN experience, so they manage the shoulder dystocias, the hemorrhages. We had a patient that had a amniotic fluid embolism about 2 years ago. She actually died on the OR table, when she had her baby, and then the emergency team, the OB team, the safety officer, and the primary attending, they were able to resuscitate her and bring her back to life. And then, she did incredibly well, and her baby also did incredibly well. So I think it's really, worth noting, even though this is more of like a midwifery discussion, that because we have the safety officer program here at NYU and here at NYU Brooklyn, we're really able to, like, when we do need to intervene for like some, bizarre or rare, obstetrical emergency, we are more than capable of handling it. Yeah. The risk of a amniotic fluid embolism is like less than 1%. Like, this is something that a person may only see like once or twice in their entire 30 years of career. And we have the safety officers. The youngest ones are 15 years out. The 2 more senior ones, 35, 40 years of OB experience. So they are, experts in the field.
Right. And how do the costs compare in general when adding a midwife to the healthcare team? And I think you had mentioned that, Shawna, you had mentioned that if somebody wants to have a midwife in a birth center, those kinds of things aren't covered. Yeah. But in a hospital, it's covered. So in the hospital, it's not going to increase the costs for a person, like the out-of-pocket costs? Okay. No. And what is the kind of costs averaging for those birth centers? Do you happen to know how much that costs for somebody to have a midwife?
Not offhand, but I have looked before and like out of state, and I've seen some places where they do like a global package where it'll be all of your prenatal visits, the delivery, and one postpartum visit. And I've seen costed like $6,000, $8,000 out of pocket. And those were in like rural areas, like, like rural North Carolina and things like that. So it may be a little more kind of in the bigger city.
Okay, right, of course. And
Yeah.
I know, like, in the past, a vaginal delivery would be like $10,000 versus like $50,000 for a C-section. But I don't think those are out-of-pocket costs. Those are just what they bill the health insurance companies.
Right.
So, what can you tell pregnant patients who are indecisive about whether they think having a midwife would be helpful to them?
I think just kind of looking at everything. Number one, looking at the pregnancy, looking at their health status to make sure that they would be good candidates for midwifery care as well. Also, I tell people a lot, like, treat this as if it's a job. Interview people. See who you're going to mesh well with. See if they match the kind of care that you want. See if the personalities match as well. But do understand that the main goal would be to keep you safe, keep the baby safe, and give you the best care possible. But definitely do your research.
Yeah. And I think it's also important to note, so for, it doesn't have to be, like, if you find the right program, right? So, if you are able to find the right program at the right office and at the right, near your house, which is really great, like, ask what the collaborating relationship is like, right? It's not even, so this is just for any patient. Like, if you're looking to have, if you're looking at a doctor, an obstetrician, that's no problem. But do they have midwives, and what does that look like? If you're looking at a midwife only type of specialty, that's fine. But what is it? What is the collaboration like between the midwife and the doctor? Like,
looking forward to have an emergency.
Like there's sometimes, like, it's, you do see opportunities where sort of like situations where the midwifery centers have they're sort of like they have the patients and they only see patients, and you can it's all midwife run, and they would sort of hire a obstetrician to do the emergencies, C-section, and sort of like intervene as necessary. That could work, but sometimes you may not be able to meet that obstetrician beforehand. And I think that's something to consider if you're looking at a midwife only specialty, as opposed to a program that has a model already integrated where you have both obstetrician and midwifery integrated within into the program itself. Like, you really get the best of both worlds.
Okay. And is having a midwife, how is having a midwife different from having a doula at a birth? And does your hospital offer both options?
Yes, we now offer both options, which is a great program that we recently started. A doula is more of a support person. They support you before labor, kind of get you educated on a lot of the things that you can expect in labor. They can support you in labor as well, like offering kind of alternative pain management options, like, breathing, position changes, stuff like that. And they also offer some postpartum support. However, midwives are clinically trained professionals that are able to provide obstetric care, gynecological care. We're able to deliver babies and things like that. But doulas are more of support professionals.
Okay. And Shawna, you had mentioned, your bio mentions that you have a focus on decreasing maternal morbidity and mortality. Do you find that midwifery can help with that, or is that like a growing problem in this state or this country? Or
I think it's a growing problem in this country. And I do believe midwifery care can help with that, but I feel that we need to kind of recognize the risks for certain patients and how to intervene and when it's necessary, and treat everybody as a singular person as opposed to like a broad spectrum of people, because this person is not going to be the same as that person. You may not always be able to manage them the same way. And I feel like that's where the kind of disconnect is with a lot of the mortality that's happening with these moms.
right.
And I would just add, the biggest difference between a midwife and a doula, right? So, like, you can also go, hire a doula for your pregnancy. So there's a huge difference between doula and midwives. Okay. So a midwife is a licensed practitioner that can perform deliveries and give you health care in a healthcare setting. they're like they have a license, they go through a training program that they have to take a midwifery board exam and to become an independent licensing practitioner to provide care in obstetrics and gynecology. A doula, it requires a certification, and doulas are great. Like they have also been shown to, because of their labor support, in making the patients trust them, and sort of like providing non-pharmacological methods to pain management, focused breathing, back rubbing, heat, temperature. Those are things that they provide, but they are non-clinical. They do not provide, they should not be providing any recommendations about starting oxytocin. They should not be intervening, with medical sort of like decision-making processes by the midwives or by the doctors. They're really just there to like support the patients, support their labor pains, labor support. They can offer lots of education and prenatal and postnatal, postpartum care. They're extremely valuable, but they are not clinicians. So that's a really big difference between midwives and doulas. And both are extremely important. We feel, and New York State, has this really big doula initiative in order to help try to decrease morbidity and mortality. A lot of the Health and Human Services hospitals all have like a New York City doula, website where they can recruit doulas. And, it's not about like, I'm going to, a lot of the doulas come in with like a sort of like an attitude. Sometimes it depends on the doula, really, what organization that they come from. They come with like, I'm gonna, fight for you. I'm going to like, fight for your right to deliver vaginally. And sometimes that creates a level of like mistrust between the patient and allowing a relationship to be established with the care team. To some midwives even, because the midwives are, so
True.
You've seen some sort of like little sort of like discrepancies in the way that they approach what labor support looks like. So I think that's really important to be nuanced. So like for anyone that's looking for a doula, completely great. We do have them here for the Family Health Center because we do believe in like the benefits of having a doula. But definitely do your research, do your look at it. It's additional cost that's usually not covered by insurances, so it's kind of like a private out-of-pocket pay, and it's different depending on different organizations and what their number of doula services that they would provide to the patient looks like. So it's very individualized, but at FHC we have free doula services because we have a really great federal grant that works with us to get the doulas here.
Oh, very nice. And at the Federal Qualified Health Center that you guys work with, do you also provide like lactation services, whether from volunteer lactation counselors or paid lactation consultants for after they've delivered?
We actually have a program in the hospital, right?
Yeah, we have the NYU Langone Brooklyn has 2 full-time lactation consultants. One of our biggest initiative is sort of like that we spent over the course of this year was to increase our breastfeeding rates. A lot of the patients here, and it's really like particular. So when we talk about ethnic disparities and like myth busting, right? A lot of the patients, like Chinese patient population here on 7th Avenue, they may choose not to breastfeed because because they feel like the American formula, like a lot of them are immigrants from China and other Asian countries, like the word is that, the Chinese sort of like formula is like really subpar and it has like, it's not really well regulated of what's actually inside the powder. Sometimes there's like higher levels of like, of metal toxins, just by the way that it's processed at the plant, can get into the formula. So that they think that American formula and like Formulac and Enfamil is like superior to Chinese sort of like formulas, and that it's actually better than breastfeeding. So that's something that we've been really working to myth bust. So our lactation consultants are hired at the hospital. They work only at the hospital. They provide services to all patients that deliver here at NYU Langone, Brooklyn. They offer like lactation support, follow-up phone calls for the outpatient setting for those that are exclusively breastfeeding, which includes the family health center patients. And over the last 3 months, we've also been incorporating a lot of the didactics that the lactation consultants give, in the hospital, in the ambulatory setting, so that, we sort of standardize the approach, because, colostrum may start in like the early third trimester for some women, and, but it's not all women. So we have to like tell them about that. Like, just because you're not making colostrum now, it's okay. Like, you're not supposed to. Like, it happens after the baby's out. So we do a lot of that collaborative approach with education for all of our patients here, especially FHC.
Very cool. So, is there anything else that either of you guys would like to add?
I don't think so. Come see us.
Okay, well, it was really great meeting with both of you. If you guys think of anything, you could just let me know. But I really appreciate your taking the time to meet with us today.
Anytime. Thank you so much.
It's our pleasure. Thank you.
Yes.
Thank you so much. Have a great day.
Thank you. You too.
All right, bye.